the questions that have already been submitted. This is a very well-informed group. I want to have time to get to more of your questions. Hopefully there will be more, which I think there will. So I'm going to talk about the Black maternal health crisis in America. I'm going to define it a bit, the who and the why speculations. Please don't worry about writing things down during my dozen or so slides, other than possibly my email address, staatsne@gmail. If you wish, I will happily share my slides and my references, which I'm going to show you. The first slide, please. So is there really a crisis? And the answer is yes, most definitely. There's always a lag in data, but this slide here shows us 2018, 19, and 20, which are the most recent years we can look at. And the numbers that you see in the rectangles are the deaths of mothers in the perinatal period per 100,000 live births. And they're divided by race, with starting in 2018, 37.3 among Black mothers is now up to 55.3. And we believe that number is actually, if anything, higher now due to COVID. Whereas if you compare it to overall at 23.8 and in white and non-Hispanics 18 to 19, that represents about a tripling of the Black maternal mortality rate. Next slide. And the next slide shows just a different way of looking at the same data. Some people prefer seeing it in a bar graph. I think the take home, one of the take homes from this is not only is it really horrific, it's getting worse for all groups. So even though our focus is on Black maternal health, we should all realize that all moms are dying at a higher rate in the last recent past. Next slide, please. This is to show you that it's a me problem. When I talk about countries, it's a US problem. So this graph, you can't see the colors very well, I apologize, but the very top line is the USA. We started out significantly higher than other developed nations. These are random developed nations to compare Canada, Germany, Japan, etc. And we are getting higher at a pretty alarming rate. And other countries are pretty much leveling off or even getting better, which you would expect that to be the case with advances in medicine. Next slide, please. So this is to try to dig into why moms are dying. And it does depend on the timing. So during pregnancy, things like severe bleeding and heart conditions are the most common causes, versus within the first 6 weeks, infection jumps up to the most common cause. And afterwards, heart muscle disease, meaning cardiomyopathy and that sort of thing. And again, I apologize, this is the latest data we have. These kinds of in-depth things take longer to look at. So it's a wide variety of factors, but many of these things can be addressed if recognized. That's a really important point. Next slide, please. So we talked about the US rates, but again, drilling down just a little bit more deeper, we see, and this is older data, so these numbers don't reflect how bad it is now, but I hope you can appreciate just a big picture look. The Southeast jumps out. It's very higher maternal mortality rates in the southeastern states. And the next slide, please. I'm hoping to illustrate something with this next slide. This shows where Medicaid expansion has not been adopted, are the states in orange. This is incorrect in that North Carolina just recently voted to adopt it, but it hasn't implemented it, and South Dakota is in the process. But hopefully you all see some overlap between those two maps. Next slide, please. So what are the factors that we think cause this increase in maternal mortality? Because if we knew really what it was, we would be correcting it and doing it, doing a better job. So
Recording in progress.
Sorry about that. I appear to have been dropped.
I seem to have a feedback issue here. If everyone could mute. Thank you. Nancy, are you still with us here?
Can you hear me now?
Yes.
Okay, perfect. Sorry about that. I don't know exactly what happened there. I lost the screen and then the sound went wild. Okay, so what are the factors? We don't know for sure, but this is our best guess. There are some underlying conditions, specifically obesity, hypertension, type 2 diabetes, that are more prevalent among Black mothers. There's also a phenomenon where foreign-born Black women have a much lower incidence of both preterm births and small gestational age infants and maternal complications. So the so-called foreign-born advantage, I would rather look at that as a USA disadvantage. Also, prenatal care quality and duration are sometimes a factor, and in segments of our population, sometimes Black people Black moms are more represented in that poorer quality. Also, we see increased rates of C-sections among Black women, and it's slightly more, but we don't understand completely why that is, although I have some speculation. Other social determinants like quality food, housing, the crime rate, air and water pollution, etc., having a job where you can go to appointments are all important. And mental health, which we're going to hear much more about later, is certainly a factor and becoming increasingly important. But what I want you to get from this slide is that education and wealth or socioeconomic status do not fully explain the differences in the increase in Black maternal mortality. Next slide, please. I think we need to go back a couple. So basically, yes, perfect. That's it. So my takeaways are that it is racism, probably not race, that is causing these problems. The second takeaway is that there are variables that we can control, mainly the early prenatal care, advocacy, which is huge, and we're going to hear more about that, mental health awareness and treatment, and also expanding healthcare to all of our citizens. And many maternal deaths result from missed or delayed opportunities for treatment according to the Commonwealth Fund. The next slide, just briefly, I feel like I could not give this talk without at least mentioning what we're about to face in the next 48 hours, where Florida will institute a 6-week abortion ban. And make no mistake, this will result in worsening maternal mortality rates for a slew of reasons. But we are about to join that big maroon morass at the southeast part of our country. Next slide. The most important thing, and I know a lot of you want to get to this, what can you do? What can be done? What can each of us do? We can all encourage Medicaid expansion in Florida. Call your legislatures, write an op-ed, talk about it among your friends and family. We need to support Black doulas, Black midwives, and other advocates for Black moms to help them through their entire birthing process, and hopefully decrease their C-section rates. We need to support birthing centers for appropriate candidates, and we can all become more informed and share that information. And I've put some documents here that I suggest, and there are multiple local and national programs, including Black Mamas Matter Alliance is an excellent one that has many events going on this week. And finally, support pro-choice legislators and legislation, because we are going to see worse outcomes, which will disproportionately affect Black women. And the next slide just shows some of the, this is the hashtag for the Black Maternal Health Week. My references, and then perfect. My last slide is just thank you so much for your attention. Again, if you would like copies of anything, don't hesitate to email me. Thank you so much, everyone.
Thank you, Dr. Staats. My apologies for all the glitches with the screen. I'm not sure what happened there. So I believe our next panelist will be speaking, Dr. Victoria McNeil-Young, and I will bring up her presentation.
Awesome. While Dr. Brennan is doing this, I just want to echo what Dr. Staats has said. Very excited to be here with you all today. Thank you so much for engaging in this conversation with us, such an important conversation and such an important topic. So like Dr. Brandon said, my name is Dr. Victoria McNeil-Young. I am an assistant professor at Jacksonville University and also a licensed psychologist here in the state of Florida. And I wanted to talk to you all today about kind of what we're seeing in terms of maternal health from the mental health side. So I'll be talking about Black maternal mental health more specifically. So, like Dr. Staats just said, mental health is a significant factor in Black maternal mortality. It is also a significant factor in just Black people's experience with reproductive systems, with mental health, with healthcare systems. And so it's a really important topic for us to be discussing. Next slide, please. So just some recent data for you all. So Black birthing people, and when I say Black birthing people, I'm just using that as an inclusive term to just kind of identify and acknowledge that not everyone who births a child identifies as a woman. So Black birthing people are more likely to suffer from mood disorders like anxiety, peripartum, postpartum depression, other type of anxiety disorders when compared to their white birthing peers. And also Black birthing people are more likely to lack clinical resources related to these conditions. And so what we're seeing from the mental health side, right, is that Black birthing folks are far more likely to experience sadness, anxiety, mood conditions associated with the reproductive experience. And they're also more likely to not be able to access services like mental health treatment before, during, or after their reproductive experience, which really contributes, right, to that higher maternal mortality rate, as well as a continuation of mental health conditions, not just peripartum and postpartum, but also throughout the lifespan. So next slide for me, please. And when we talk about this, again, what Dr. Staats said beautifully, we really have to try to understand kind of why these things are happening. Like she said, it's not race, right? It's racism. And in order to understand the experience of Black birthing people and reproductive systems, we really have to understand the concept of intersectionality, okay? And so, when we're talking about intersectionality, really what we're looking at is the ways in which systems of inequity and inequality based on things like gender, like sex, like race, sexual orientation, socioeconomic status, are really going to intersect to create unique experiences that affect the reproductive process, the process that Black folks have in healthcare. And so the Black experience in healthcare is a unique experience that can shift individually from person to person because of intersectionality and because of varying levels of privilege and oppression based on unique identities. Next slide, please. And so, when I think about intersectionality, right, I think about a Venn diagram. That's the easiest way that I kind of conceptualize it. It's not so much our individual identities of race, gender, sexuality, socioeconomic status, but all of those identities are coming together in order to create a unique experience, right? So I identify as a Black, cis, straight woman, okay? My identity as a Black, cis, straight woman we can't separate my race or my gender or my sexuality out from that. And my experience with my identities may have some similarities to another Black person, and it's going to have some differences than another Black person. But what we know, okay, is that race or racism is a determinant of the ways in which Black people interact within something that we know as the medical industrial complex. And so if you see the kind of graphic on the right, the medical industrial complex really is just a network. It's a network of interactions that folks have when they are interfacing with healthcare. So it's important to understand that when we're talking about maternal mental health, we're understanding that Black birthing folks aren't just interfacing with an OBGYN or with a hospital system. They're also interfacing with pharmaceutical companies, they're interfacing with mental health care, or not interfacing with some of, like, not having access to these resources, right? Also, there are things that come up related to safety. We have Black birthing people giving birth in different types of environments that are also tied to the medical industrial complex. And so it's really important to understand that we are trying to look kind of holistically at the ways in which racism and discrimination can show up in these settings. It's also important to name, right, that the medical industrial complex historically has operated from a very Western or European worldview, meaning that other cultures, other ethnicities, other viewpoints may not have been as recognized. And that's also contributing to the disparity that we see related to maternal mental health, because that interaction can lead to both historical and present experiences that have been harmful to Black birthing folks. So let's talk a little bit more about specific factors. Next slide, please. So this is by no means an exhaustive list, but we do want to kind of shed light on some of the factors that are influencing Black maternal mental health, just kind of generally. So number one, a lack of culturally competent providers, right? It is important to note that sometimes these types of conversations are not happening. They might not be happening in medical school classrooms. They might not be happening on OBGYN floors. They may not be happening in the spaces where they probably should be happening. And so when you have a lack of culturally competent providers, number one, Black birthing people often don't feel safe interfacing with those providers. Number two, the lack of cultural competence can prevent people from even getting access to those providers. And so that can definitely have a negative impact on mental health. That can add to symptoms of anxiety, symptoms of nervousness, symptoms of stress that can have those long-term effects. We also need to name and understand that Black birthing people are kind of saddled with the unique experience of historical abuse, right? So we know very terrible things have happened to Black birthing folks in the past, forced sterilizations, not having their needs met, and that also can contribute to anxiety throughout the entire reproductive process. There's also implicit biases related to pain. I also really liked what Dr. Staats said related to how socioeconomic status is not a determinant for maternal mortality, okay? So we know historically that Black birthing people, Black women specifically, have historically not been believed when they have made, when they have advocated for themselves or when they have expressed having pain issues, being concerned about their level of pain. And so very frankly, sometimes we have Black birthing folks in hospital systems that are advocating for themselves and saying that they're in pain, saying that something's wrong, and those folks are getting ignored. I think the most recent kind of high profile example of this is when Serena Williams, who we all know, famous tennis player, gave birth to a child, or her child was having blood clots, which she had a history of this. And the doctors were kind of disregarding what she was saying. She had to do a lot of self-advocacy, and actually her husband, who identifies as white, had to do a lot of advocacy for her as well. There's also inaccessibility of mental health and reproductive health services, and also unsupportive work and hospital policies that can influence the lower rates of Black optimal maternal mental health. Next slide, please. And so, really when we're thinking about all of these experiences, they can lead themselves into number one, an experience of trauma and an experience of identity-based trauma, race-based trauma, discrimination. And that trauma can interface and can add to the experience of PMADSs, which we know as perinatal mood and anxiety disorders, okay? And so there are kind of three major types of perinatal mood and anxiety disorders that, you know, we focus on in the mental health side. And all of those factors that we've discussed can lead into those. So first we have peripartum depression, meaning that, you know, birthing folks can start to experience those symptoms of depression prior to giving birth, right? And so feelings of sadness, depressed mood, severe mood swings. Most of the times we're talking about those types of symptoms after a child has arrived, but it can occur anytime during the, you know, the conception process and after conception. We also then have postpartum depression, which is happening after a child has arrived. And then the most severe case is postpartum psychosis, meaning a very severe, very intense kind of experience of postpartum depression, having hallucinations, having delusions, sleep disturbances, and paranoia. What we are seeing is that peripartum depression, postpartum depression, and postpartum psychosis are on the rise. They're on the rise just generally, but significantly among Black populations. So the risk for PMADSs are 1.6 times higher for Black birthing people than for white birthing people. And so this is definitely a topic that needs attention and that we need to address. So how do we support Black birthing people in terms of maternal mental health? So next slide, please. There's a number of things that we can do, right? And hopefully we can continue to have this conversation during the Q&A. But the first thing is to listen to Black folks, right? Listen to Black folks related to their experiences in the health system, listen to Black folks related to their reproductive experiences. Also listen to Black folks related to their fears, right? And validate those fears because they're based in reality. Also increase peripartum and postpartum education, increase access to mental and reproductive health services, and then very important to help to increase mental health screenings during pregnancy. You would be surprised at the number of birthing people who do not get a mental health screening during pregnancy, or if they do, it is a very kind of face value mental health screening. What we know about Black mental health is that the language that maybe the general population uses related to their mental health experiences may not be how Black birthing people are expressing or naming their experiences. So we really have to be conscious about how we ask questions and make sure that we're asking thorough questions. And lastly, it's really important for us to be partnering with Black maternal health services. And we're going to hear from two great ones today. So again, thank you so much for your attention and for engaging with me on this. I'm very excited about the Q&A and happy to answer any questions and engage in discussion a little bit later. Thank you.
Thank you, Dr. McNeil-Young. I'm going to pull up the next set of materials from our next presenter, Faye Johnson.
I just want to say thank you all for inviting me to be on this panel. I'm very excited about it. I ran out of time and I wanted to do this 10-point PowerPoint and everything, and I couldn't get it done, but it's okay. We're here. And thank you all so much. And Dr. Staats and Dr. Young, I appreciate your comments and your topics. It is point well taken. And we are here as an organization. The Northeast Florida Healthy Start Coalition has been around since 1991. We are a maternal and child health organization here covering the Northeast Florida area. And today I celebrate with you this week around Black Maternal Health Week. And it is so exciting and so important that we share this information with the community. Next slide, please. The Northeast Florida Healthy Start Coalition services that we provide are listed, but we are one of 32 coalitions across the state, across Florida. And we function under the Florida Association of Healthy Start Coalitions. As I said, we were organized in 1991 to reduce Florida's high infant mortality rate through the Healthy Start initiatives. And our coalition leads the community to reduce infant mortality and the deaths of children, improve the health of children, women of childbearing years, and their families, to include fathers in 5 counties. Next slide, please. So our programs, we have several. We have many programs, which is a blessing, to be honest with you, for our women in the community that really need the support. We are there with Healthy Start is one of our programs that is a home visiting program. And these are some of the resources that are available to all women, regardless of income level. It doesn't matter. When we're supporting women in the community and families, income should not matter. We should be able to serve everyone, and everybody feel free to be able to obtain those services. We also have Healthy Start services for our pregnant mom and our newborn infants, and we cover 5 counties with that. The Azalea Project is a specialized program along with the Rose Project. I don't know what happened to my Rose diagram logo there, but it's specific for substance abusing pregnant women that have a disease of substance abuse, so we serve those women as well. Our Connect program connects all women across 5 counties to enroll in any home visitation program for support of their choice. It is a choice they choose. We don't tell them which one to choose, but it's for all women and their babies. And our National Health Corps is a program that really trains other individuals to be volunteers and sort of like members. They're not employees in the health field, and they work in a lot of different organizations. I think we have 21 members at 21 different organizations around the coalition. And then we also have the Fatherhood PRIDE program, because when we think about mothers and Black mothers and fathers, we need to think about the dads as well, supporting them in their role in the space of maternal mortality, because they play a significant role. And so our fathers are there providing services for them. And then our Magnolia Project, which I'm going to touch on a little bit as we talk through this talk, is our federal Healthy Start initiative that is to eliminate racial disparities. And that's where the most of our work is done around the foundations and inequalities of infant mortality and maternal mortality, because it has a history, as you've heard. There's a history with this. There's some generational things that have occurred from years that carry over from one woman to the next woman to the next family and the next family. So we have to understand the history, as Dr. Young said, to understand where we are in this space and the things that we need to be aware of within ourselves as African-American women and families. You know, we need to be able to provide that support across the board and make it known when there are issues that we need to speak to it, speak truth to it, speak to it. You know, there's no harm in that. And we should be allowed and be able to do that throughout our career. Next slide. So, I had 2 slides in there, I'm sorry. The Rose Project, I had a short time, is also our other substance abusing program for pregnant women. So these are our programs across the board. And then our most recent campaign is specifically to address the racial disparities of Black infant mortality, and it's called Hey Mama Campaign. And this is one of the newer campaigns that we're running since I think we're in phase 2 now, to address the high infant mortality rate in zip codes 32208 and 09, predominantly African-American communities, where we serve, and we are putting out your body is powerful. You know, you are supported. We want the images to be powerful. We want women to know that they are important. They have a voice to speak as we think about advocacy and those type of things. So this is our most recent campaign that is airing, and it talks a lot about the history and everything that we're covering for Black women in our community. They need to understand they have a voice, and we want to give them the tools necessary to use that voice to advocate for change, to advocate with their providers, to talk with them about when they feel that they're not listened to. So we want to continue that program as well. Next slide. So the Magnolia Project, and I'll talk about the Magnolia Project a little bit. It is our federal Healthy Start initiative that was started about 15, 16 years ago, maybe a little longer, to eliminate disparities in perinatal health. And the Magnolia Project is an interesting program because it looks at the life course model, by Dr. Michael Liu, that is grounded in when your child is born, from the day the child is born through the life of that child up to motherhood or childbearing years. Her life has already been impacted by circumstances, whether it be racism, discrimination, or whatever. Life has already been impacted, whether it be socioeconomic status. From the day that child is born and moves into childbearing years, the life course approach focuses on the social inequities and the social determinants of health. And as you all know, the social determinants of health are where people live, work, play, all those things contribute to maternal mortality and also infant mortality. And when you think about Dr. Liu's work, Dr. Michael Liu's work, he talks about, like I said, from the beginning of time, how things that impact the child's life to a period. And he says it's racism, it's not race, it's continual as you look at the weathering effect that women go through and Black women go through for years of the effects of weathering. And that term alone, and let me just describe it a little bit for you, because weathering to me, when I started to really research and do a lot of work around this area, the toxic stress that plays on the body through the weathering effect, if you think about it, through years of something just beating you down in a way, no matter whether you're a fluent African-American woman, you're low income or whatever, it just continuously beats your body down. Think about what that's doing to your organs. And every time, by the time you become childbearing years and by the time you become pregnant, think about the wear and tear that the body has gone through mentally and physically, just by those things alone, just by trying to work 2 jobs at a time and make ends meet and those type of things, are taking the systematic abuse that has happened through the years and those type of things that has happened. When you're trying to get your care and you can't get the quality care that you deserve or need and those type of things while you're trying to raise your children. All of these things, the weathering effects takes a toll on the body, racism takes a toll on it, and over and over and over. If that occurs too much, then you have the diabetes, then you have the hypertension, then you go into the pregnancy with all these things. It's almost like, and I tell people all the time, I use this analogy of a ship. If you have a ship that's being battered through the waters for years and years, and you have this cargo on it, this precious cargo like a baby, that all of a sudden enters the ship, and you're trying to carry that cargo safely across. By the time that battered ship gets to the other side, the cargo may have some challenges. Our babies may have some challenges. Our moms may have some challenges during delivery and after delivery, and therefore they may not make it to the other side. So we have to think about the weathering effect and what that does to our families and our mothers and the babies going forward. So therefore, when you have doula services in our group, what we do in the Magnolia Project, we have a doula program, which is a support system for women to help them advocate for themselves in the hospital systems, outside of the hospital systems, just in advocating for changes for themselves or having that level of support, because it's so important just to have someone to talk to sometimes, just some support. You know, may not have all the right answers, but they know the resources. And a lot of the women that work in the Magnolia Project, and to include myself, we have lived experience. So we're able to really talk about the lived experience with our women as they go through their changes and their circumstances. So it's very important to have those support systems in place that we have through the Magnolia Project. And now we're also expanding, not just Magnolia, our other programs as well have similar support systems. But I want to speak specifically to the Magnolia Project because it is grounded in eliminating racial disparities in perinatal health. And so with our doula support, and I thought I had a picture, I don't know, it may come up, it may pop up later, but our doulas, there it is. Our doulas are trained and supported and work very hard to ensure that our women have the support in the services, because it is difficult to maneuver and manage some of the system issues that are out there that they face every day. When you can't get into prenatal care because they're OB deserts, when you can't get into hospital systems and things like that, when you're trying to make everything come together and nobody's listening. When I say I'm really hurting and I'm in pain, or my feet are swollen, and you don't, you can't take the time with me to understand my pain. And in some cases, even my grief. So we have to understand that, and the programs that we have, we're there for all women. But when you have a group of women that have gone through so much through the weathering, we try to get them to understand stress and what stress is doing to their body and how that's breaking down their system as well, and try to get them to understand and work through some of those stressful situations and provide their support. So Magnolia is one program, but I wanted to focus on that one because it is our specialized program around eliminating racial disparities in perinatal health. And we are here. I look forward to the discussion as well. There's a lot, there are a lot of resources out here, but we have to assist our population of women to make sure that they know where those resources are and that they're welcome to those resources. It's not a stigma, it's not anything against you or anything like that. This is yours, it's yours to have. And so for that, I just want to say next slide and thank you. And that's my coalition. This is the next thing. I forgot about this one. No, go back, one more. I had one more, I forgot. So one of the things that I believe in, and we just were awarded a 5-year grant, because I believe in upstream work. And we see we have a lot of programs and everything, but until some of the policies change, we're going to continue to see what we see. We're going to continue to see what we have. And so our work around, we just established the Northeast Florida Maternal and Child Health Policy and Research Center, which launched through as a part of our Catalyst grant through HRSA. And so having said that, we are now really digging deep into some of the issues, systemic issues that have policies attached to them that we need to teach our women how to advocate and bring about change to change some of those policies. Because until some of those things change, we're going to continue to stay the same. So with that, now I'll end and say thank you. Thank you so much. And that's my contact information, but I look forward to the discussion as well as we go forward. Thank you.
Thank you, Faye, so much for your presentation. And now I'm going to turn things over to Kimberly Homer, who is our midwife and can talk about some real life stuff. So let me pull those up. Make sure I can find it. Why is it not here? My apologies. I'm not sure where it is. I thought maybe it was here. Ah, let's see. Nope. Just bear with me one moment. Okay, share. All right, can everyone see that, I hope?
Yes,
Yes.
I can see it.
Perfect, okay. All right, I will turn things over to you. Thank you very much.
Good evening, everyone. Thank you for having me and thank you for inviting me. I am what is called a direct entry midwife, and what that looks like when it comes to education. The school I went to trained me strictly in midwifery care, so similar to obstetrical care, but without the surgical aspect of it. So I am a healthcare provider. Next slide. So the role of a Black midwife, and we're not just midwives during the childbearing cycle. We encompass a lot of roles in our community. And as you see on the slide, the role of a Black midwife in underserved communities is crucial in providing access to high quality maternal and reproductive health care. And what I mean by that, high quality maternal and reproductive health care. We spend a lot of time with our patients. Our patients, we get to know them as actual individuals. We understand how their family is growing. We try to learn what they need and what we have to offer and see if we can even fill in that gap or at least lead them in that direction. In a lot of the communities, there's, as you've heard several times throughout this evening, there are deserts when it comes to healthcare. And when you look at midwives, we're working in the communities that we live in, and we're serving our neighbors, our friends of friends, and we can actually fill in that gap. As you see on the picture, I'm out in the community spreading the word and giving awareness about midwifery care. A lot of people are unaware of what the midwife used to do just even decades ago. we didn't serve not only during the childbearing cycle, we were somewhat of the healthcare provider for our actual community. I'm a storyteller, so I like to share some of my experiences. And as most recent as today, I had a mom who contacted me. She delivered over a year ago, but she keeps in touch with me anytime there's anything that happens relative to her reproductive system. And we've had several follow-ups in reference to pelvic floor care, and assuring that she got the pelvic floor assistance that she needed when it came to recovery after having not one, not two, but 3 children. And we're making sure that we involve our actual community, because there are so many resources around us if we involve them, especially like holistic, alternative. And I'm not that fond of the word alternative. It's just another resource, whether it's chiropractic care, acupuncture, even as far as womb wellness care. We could go to the next slide. So we have what's called the midwifery model of care. You have the midwifery model of care and you have the medical model of care. So to tell you a little bit about the midwifery model of care, it is based on pregnancy and birth as normal life events. What's included in the midwifery model of care, you have the monitoring of the physical, psychological, and social well-being of the mother, birthing parent throughout the entire childbearing cycle, from preconception all the way to postpartum. We're providing the mother and birthing parent with individualized education, counseling, and prenatal care. We're continuously giving hands-on assistance during labor and delivery and postpartum support. For example, one of the differences between midwifery model of care and the medical model of care, looking at just the postpartum aspect alone, when delivering in the medical model of care, obstetrician 6 weeks after delivery. When it comes to the midwifery model of care, you see your midwife at least 3-4 times within that postpartum period, just to assure that your transition into your new normal is going well. We want to make sure that you're healthy, that your newborn is healthy, that you are physically healthy, mentally healthy, emotionally healthy. We want that alignment from head to toe. And that is what we're doing. We're giving you support. We're making sure that you're accessing, or at least understand what your resources are around you. Also, in the midwifery model of care, we're minimizing technological interventions. So we're incorporating the natural, traditional, cultural methods of care, whether it's something indigenous to your culture or something indigenous to our culture, or just traditional care, which happened hundreds of years ago. Incorporating herbal care, incorporating, like I said earlier, chiropractic. You just never know what the individual body may need during that care, but we want to make sure that you understand, regardless of what's going on, you have options and you're not limited. Another thing when it comes to the midwifery model of care, we are identifying and referring women and birthing people who require obstetrical attention. We take in low-risk families. And in some cases, we're able to offer collaborative care as well. And with collaborative care, you can have prenatal care with a midwife and still deliver in a hospital setting if you're high risk. We're still monitoring you the same way, but you still receive that individualized care. Next slide. How can you help Black midwives help their community? One of the biggest ways that you're able to do that is by promoting diversity in the midwifery profession. When you look at the entire profession of out-of-hospital practicing midwives, the percentage of Black midwives is less than 5. And that's alarming. When you look at the numbers of the maternal mortality rate alone, when you incorporate the statistics of healthy, safe labors, deliveries, and moms within their first year, birthing parents within their first year, their health, their knowledge, their education when it comes to their physical body being, their mental health. The numbers are there showing you that midwifery care, especially from someone that looks like you, is very imperative. It makes a difference. Improving access to midwifery care. Every state isn't the same. Luckily, in the state of Florida, when it comes to midwifery care, we're one of the better states, but we still answer to a higher power. We still have rules and regulations that we go by. But in reference to access to midwifery care, we are able to take insurance, but for some midwives, it's hard to become in-network providers. So talking to your insurance company to assist us in that process, because insurance companies would not exist without clients. When we're writing or filling out applications to become in-network providers and receiving letters that say, oh, we have enough midwives in network in your area, so try again next time. And with most insurance companies, they only really require 1, maybe 2. So that's another way you can help your local midwife when it comes to access to midwifery care. Addressing racism and bias in healthcare. It doesn't happen solely with patients. It happens with your midwives too. When every midwife is not a rebel when it comes to home birth. We look at the individual person to make sure that they're low risk. If we notice or detect anything that would risk you out of care, our first line of action is to make sure you get the care and you are where you need to be. Sometimes when we're transferring, the hospital system makes it a little hard. And I've experienced that firsthand as well. Like I said, I'm a storyteller. Recently, a couple months ago, I had a mom, full term. I sent her to get an ultrasound and her fluids were low. Her fluids were gastronomically low. I sent her to get a second opinion in labor and delivery at a particular hospital in Jacksonville. And they didn't even want to give her a second ultrasound, although she had the actual ultrasound that said, okay, I'm at risk. My baby's at risk. All they wanted to do was listen to the baby. They didn't even want to look and see if her fluids went up or went down. So I'm on the phone with this family, teaching them how to advocate for themselves and using certain keywords and trigger words in hospital settings can get them moving. And once my client advocated for themselves, I'm sorry, because it really heats me when we don't get the care that we deserve. At that time, when my client finally got her ultrasound, there were no fluids to even measure. So she was immediately admitted. This is 2023, and this is still happening. So when it comes to advocacy, it's the education, it's knowing not just what your rights are, it's speaking them into filtration. It's standing on your word. It's knowing that you have a voice. And sometimes we've swallowed our voice so much where it's a process relearning how to even speak in certain spaces. One of the most important things when it comes to helping midwives, Black midwives help their community, we need more Black midwives. Simple as that. And it's a challenge when it comes to a lot of Black midwives in midwifery school, because you have student midwives that are managing their household, working 2 jobs, trying to pay tuition. They're doing clinic, they're on call, especially as a direct entry midwife. When you're on call and you get called in, you don't know when you're coming home. Birth has no schedule. So once you're there and present with that family, you don't know when you're coming home. And being able to create